Today, what I want to do is to describe two aspects of my work. One that revolves mostly in a clinical scenario in which randomized trials are available, but they provide insufficient or incomplete answers, and this will be the work that we do mostly in first episode psychosis. And then I will highlight some of the work that we do in suicide prevention, and this is mainly a scenario in which randomized trials are unavailable directly. And then I will close with some future research directions. So the first part of the talk, I want to describe a scenario in which we have randomized trials, and I will say a few words about these trials. These are monumental efforts, and they are addressing all the right questions, but as I will show you, they provide incomplete answers. Once the trials are published, we are left with many questions about disease-modifying strategies in first episode psychosis. So the background or the rationale is that in patients who will later develop chronic psychosis, there is a proposal that there exists a window of opportunity. This window of opportunity is this period that's in the green circle here, where the patient has just had their first episode of psychosis or right before they experience their first episode of psychosis, and the episode of psychosis is represented here by these peaks in the blue line. So it's very early in the trajectory of the disease, and it is proposed that if we intervene in that particular time, at that particular moment, then if we find the right strategies, of course, then we would be able to later prevent or alter the course of the disease. The course of the disease is very devastating. Patients usually suffer multiple episodes, and even if they don't suffer episodes, they are left in a chronic state of disability where it's very hard for these patients to sustain relationships, works, even studying. So it really affects the quality of life of these patients. So it's a great thing that that we are provided with this window of opportunity to really implement disease-modifying strategies. But the problem is that to learn what are these disease-modifying strategies that we need to implement in this very time-limited period, randomized trials are very hard to conduct because, as you can see in the whole evolution of these patients, we are only given a tiny window of opportunity. So we need to recruit patients at specifically that part of the disease, which I'm sure you can understand that this is really challenging. So most of the clinical decision-making in this part of the disease, which is the most important part of the disease, are made mostly based on clinical consensus or extrapolating what we know in patients in later stages of the disease. Some of the disease-modifying strategies that have been proposed is that if we choose the first antipsychotic well, we have a very large list of available antipsychotics, but if we were to choose the first antipsychotic well, then we would maximize the adherence of these patients and we would prevent the first relapse. Being the first relapse, the most important factor that determines that the patient will have a poor chronic disease trajectory. So if we were to prevent that first relapse, then we would be doing a lot in preventing the chronic evolution of these patients. Other strategies that are proposed in this green window of opportunity that we can intervene early are transitioning from oral to long-acting antipsychotics, because long-acting antipsychotics, they maximize adherence and they might prevent relapses more efficiently. Another question that has been proposed is for how long we need to treat patients with antipsychotics. If we treat them for short periods, then we might be increasing the risk of relapse. But if we treat them for too long, antipsychotics are also associated with decreased quality of life, very severe side effects. So we need to find the optimal treatment duration, which can also, of course, influence how these patients are going to develop later in life. So as I said, there are randomized trials. These are, to say the very least, these are monumental efforts in gathering patients with first episode psychosis in this tiny window of opportunity that we are being offered by the disease. And I'm saying it's a monumental effort because it's not only that's very challenging to recruit patients in this very specific time of the disease, but also you have to put yourself in the shoes of these patients, that they are not really sure what is going on. They have just had a first episode of psychosis. They don't have a diagnosis. They don't know what's going to happen if they are going to experience many episodes. They don't know if they have to take medication for life. And so somebody comes and they ask them to be participate in an experimental trial. It might be very disruptive. Many patients they don't want to participate in these trials. It's very hard because it is not clear what's going on with them at the time. So this first trial that I'm going to describe is the UFES trial. It was published in 2008, but it started around in the early 2000s. It involved 14 different centers in 14 different countries in 3 different continents. So it's a huge monumental trial. They were able to gather 500 patients. And in this trial, they compared the first choice of antipsychotic agents, and they found that some agents were doing better than others in terms of the primary outcome, which was treatment discontinuation. So the blue line here representing olanzapine, which was one of the newer antipsychotic agents, was showing a better profile in terms of treatment discontinuation. An interesting fact about this trial is that when the trial was proposed, funded, and it started in the early 2000s, the investigators compared these 5 antipsychotic agents. This was in the protocol of the trial. But by the time that the trial was published, clinical practice had changed so much that these antipsychotics were rarely used in clinical practice. Of course, because the trial took so long, and it's understandable, when the results reached clinical practice and clinical audience, the clinical practice had completely changed its shape. And psychiatrists were using completely different agents. Another interesting example from the same group was published last year, another monumental trial for a large number of centers in different countries. They were able to recruit 500 patients in this particular time of the disease, and they compared transitioning from long-acting to oral antipsychotics. And these are the Kaplan-Meier curves showing that the blue line here, which is long-acting antipsychotics, after a period in which the curves overlap with each other, showing that there's little, if any, effect of transitioning to long-acting antipsychotics. After a while, the curves start to separate, and the trial was reported as negative based on the p-value in the Kaplan-Meier curve. But the clinical audience was left with the feeling that the curves were showing a separation that probably, if the trial had lasted for longer, then we might have observed a better result. And the other thing that, of course, was imprecision, leading to the finding that there was no statistical significance. But to the clinical audience, there was a promising signal in the separation of these curves, and they wanted to see what would have happened if the trial had lasted for longer. The last one is what I think is the most relevant question for this patient, is how long do we need to use antipsychotics in patients who are responding well? This, to me, is the most interesting and most relevant question for these patients, because if you treat them for too long, it has been shown that antipsychotics, they have deleterious effects on the brain, and it can affect negatively in these patients in the long term. This trial is particularly hard to recruit. It's particularly hard because patients, they don't want to be randomized to a treatment strategy that involves maintaining antipsychotic treatment for more than 2 years. They don't want to hear the first thing about that. When they remember that these are patients in a very early stage of the disease. So even if they want to participate in a trial, they don't want to have a 50-50 chance of taking treatment for 2 years at this very early stage of the disease. So this is extremely challenging trial to conduct. This is a trial that was just published a couple of weeks ago. It took more than 8 years of recruiting, and they managed to gather 300 patients. And as you can see, there is a signal suggesting that as a shorter time of antipsychotic treatment might benefit. The primary outcome here is a scale of global functioning, and that patients who use antipsychotics for shorter periods, they might have a better functioning. But the estimates are very imprecise. As you can see, the confidence intervals mostly overlap with each other. So the clinical scenario is that randomized trials, they are only providing partial answers, and it is not very likely, given what I told you about the difficulties with conducting these trials, that we will have better trials anytime soon. So in this context, we can use observational data to complement existing randomized evidence. This is, I think, that a very clear scenario in which we can complement and create a dialogue between randomized trials and people who do randomized trials and people who work with observational data, because the need is very clear. It is very clear that randomized trials will not have definite answers for these questions anytime soon. I'm guessing you are all very familiar with the target trial framework, and in this case it's very clear because we want to align observational randomized evidence. Then we need to specify a clinical question in the observational data as a hypothetical randomized trial, which is the target trial with the components that you have heard and know about. The one difference in this particular scenario is that this step is simplified because what we want to do is actually complement results from a trial, and so the protocol of the trial is available to us. So the protocol in the specification of the target trial, this step in which we specify the protocol, is simplified because we know what the protocol should look like. We have a problem if we wanted to use observational data to complement results from the trial, and the problem is that, as you well know, is that we need data to emulate each component of the target trial. And this is a particular problem of mental health, is that we typically lack information for most important variables that we need to emulate a target trial. In mental health, for example, we don't typically have available data on confounders. And when I say confounders, I think about the factors that psychiatrists use to decide one treatment or the other. Psychiatrists make treatment decisions based on disease severity. They make treatment decisions based on predicting adherence to certain treatments. So substance abuse is a key factor that we don't have typically good access to in most observational data. And when I say observational data, I typically refer to EHR data, claims data in the US, or registry data in Europe. When we think about outcomes, relapses, or functional status, in the last trial that I showed you, the main outcome that we want to look is how the patient is functioning in the real life in the long term, and this is a variable that's not typically available in most observational databases. In psychiatry, there's a very well-documented lag between the appearance of the disease and when the disease is actually recorded in the observational data. So the exact onset of the events is rather obscure in mental health. So there are many problems, and so if we wanted to emulate a target trial, and if I wanted to be more concrete about this problem, is that if we think about the target trial, then it would become clear that we lack information to, for example, appropriately emulate the randomization in one of these randomized trials. So if we wanted to update the first randomized trial and use agents that are more typically used in clinical practice, so the UFEST trial that I described, if we wanted to update the results from that trial to the antipsychotics that psychiatrists are using nowadays, we would be facing these difficulties. The first difficulty is that we would need to account for the factors that make psychiatrists choose one antipsychotic or the other, and most of those factors are not available in observational data. the outcome, which is psychotic relapse, we might psychotic relapse, just for those of you who it might not sound familiar, is not only if the patient is hospitalized because of a psychotic relapse, but there are many relapses that are managed as an outpatient basis. And those relapses in which the patient is not hospitalized are typically described or defined based on clinical severity, which is another variable that we don't have access to. Not to mention that if we wanted to estimate a per protocol effect, then we would need to have factors associated or risk factors associated with adherence and with the outcome. So we need, in order to emulate these target trials, in addition, what we need is to complement EHR data. We need to complement EHR data with clinical information, with risk factors for relapses and risk factors that predict adherence, and of course, functional outcomes. So this is what we have been working for the past 5-6 years, is to create an improved data resource that would allow us to use observational data to emulate target trials in first episode psychosis. Essentially, what we do is we contact the clinical experts in first episode psychosis, because they typically they have access to a clinic that treats patients in the very early stages of first episode psychosis. And what we do is we work closely with these clinical experts that lead first episode psychosis clinics. And what we offer them is to complement the EHR or the data they have with the variables that we need for target trial emulation. And the response that we typically have is, of course, as long as you do all the hard work. And so these are the cohorts that have agreed to participate. Most of these cohorts, as I said, they contribute data, but another very important feature of the collaboration is that each of these clinics are led by clinical experts in first episode psychosis, which makes all the discussions about research question more interesting. When I say that we have to do the hard work, is because essentially what we do is we complement the variables that are available in the EHR data with variables that are updated at every clinical visit, and the variables that are updated at every clinical visit, which are the variables that I mentioned you a couple of minutes ago, these variables we need to adjudicate by clinical experts. What we do essentially is we go to the clinical notes and we try to extract the symptoms, the severity, the substance abuse, the working and educational status, the side effects, and all of the variables that are not readily available in the EHR, we extract them. And we create a team of people with subject matter knowledge and people who, for some variables that are straightforward, that might be easier, but it's definitely a lot of work. This is, of course, this can be done because each cohort, as I showed you, they contribute with around 200-300 patients. So we are not talking about huge numbers, but these are small cohorts. But when we harmonize them together, the numbers start to grow. And if you think about the numbers that are available in the randomized trial, the sample size of the FEP-CAUSAL collaboration little by little starts to grow, and it's now almost 10 times the number of patients that are randomized in a typical trial evaluating these patients. So once we have the data, we create this collaborative model in which trialists and patient and observational researchers, they collaborate together and they work together in the design of the target trial emulation. And these are very fun meetings because we think about these problems very differently, the trialists and the observational researchers, but we learn from each other. The trialists, they see this, it's fun, but they see this as a second opportunity to design their trials. Is that if they were given a second chance, how would they design the protocol differently? So that's one of the things that they see in these meetings as being fun, and they learn. They are, of course, it is not easy for them to accept that it's the same or that it can be approximated with observational data. But they are very open, and when we have these discussions, and it's very nice to learn from the other side as well when we do this. And for us, from our observational research side, we of course use the results of the trial as a benchmark to assess our observational estimate. So we can use the results that have been produced, even if they are not definitive, we can use them as a benchmark. We know that those results are unbiased, so we can use them to assess our observational estimates. And as I will show you in a couple of minutes, this is super useful for us to learn which outcomes or which analysis we can emulate with observational data and which outcomes we can't. And this is also useful for other observational researchers, because we can say, this was our experience, this outcome or this analysis, we were not able to emulate, so don't attempt it, or maybe try to find a way of doing it better than us, and then for which outcomes we were more successful. This is what we did with the first of the trials that I described in choosing the first antipsychotic. So what we did was we worked with the investigators that were participating in the UFES trial, and we designed a trial that looked very similar, but in blue here I'm listing the antipsychotics that are more frequently chosen in clinical practice nowadays. So essentially it's a trial that emulates the UFES trial, which is the index trial. It looks very similar to that index trial, but it, in addition, compares antipsychotics that are more frequently used in clinical practice. We use the same outcome as the UFES trial, and we added psychotic relapses in addition to all-cause drug discontinuation as the primary outcome, because it was a measure that was more relevant for patients. Of course, for sample size considerations, this was something that was not able to be seen in the UFES trial, but because we have a larger sample size in the FEP-CAUSAL collaboration, then this was something that the trialists were saying, that if we had access to infinite sample size, we would have looked at psychotic relapses as the outcome. So this is something that we can incorporate in the protocol of the target trial using observational data. And then we adjusted, or we emulated the randomization using the variables that we had collected so carefully, and that we think are the variables that psychiatrists use in making these clinical decisions. So we applied the eligibility criteria from the UFES trial. We were left with between 100 and 400 initiators of each of these agents. The first three agents here, olanzapine, quetiapine, and first-generation agents, these were the agents that were used in the UFES trial, in the original trial, and these last three boxes are the antipsychotics that are more relevant in clinical practice nowadays. We are including these three agents only for benchmarking purposes, but we are more interested in seeing whether there is any difference with those last three boxes. These are the results from the trial, and the first thing that we learn, if you look at the first row for when it says UFES trial, and the first row here where it says observational analysis, FEP-CAUSAL, you will see the primary outcome from the trial, from the UFES trial, showing that olanzapine was showing a lower non-adherence than the other antipsychotics. And we were when you look at the absolute risks of treatment discontinuation in the trial, and when you look at the absolute risk of treatment discontinuation in our observational data, you will see that these are widely different. And these are widely different because, of course, clinical and adherence patterns in observational data and in randomized trials are so different. But in addition, there's an interesting thing that after the publication of the trial itself influenced the way in which psychiatrists were prescribing medications. And for example, the UFES trial reported that there was a huge weight gain increase with olanzapine, so most psychiatrists were stopping olanzapine at very early when the patient was gaining weight. So there was this feedback between the results of the trial the clinical patterns and the observational analysis, if you can see that path going on. So we reported that treatment discontinuation was an outcome that we were not able to emulate with observational data based on these results of how previous trials influence clinical practice and how clinical practice influence adherence patterns that we see in observational data. But we said that, for example, for psychiatric hospitalization, the benchmarking processes was very successful, as you can see that the absolute risks for hospitalization were very similar between the observational data and the trial data. Of course, this was the first paper of the FEP-CAUSAL collaboration, and it was very hard to convince psychiatric journals that this had any clinical interest. Why are you showing us this if the experience was unsuccessful? So this in the end, in the epidemiology, in an epidemiology journal, it was more clear to see the benefits of doing that and reporting the benchmarking processes, even if they are unsuccessful, and so that future researchers can understand what can and can't be emulated with observational data. When we extended, we found a better pattern of adherence with the antipsychotics that were more recently used, aripiprazole and paliperidone, and this was a finding that was reported and said, which is consistent mostly with clinical practice, that these two antipsychotic agents are chosen as first line. They have a lower rate of side effects, which can explain why patients discontinue these antipsychotics in a lower risk of treatment discontinuation. We did the same with the second trial. We worked with the trialists in the oral versus long-acting antipsychotics. We went through the same. We worked together to align the protocol of the target trial with the protocol of the trial that had been published, and we were able to recover similar estimates for the long-acting treatment and the oral treatment, the risk for hospitalizations at 18 months. So you can see that the risk of hospitalization, if you transition to long-acting, was 18.5 in the trial, 22.0 in our 22.0 in the randomized trial, and 18.5 in our observational data. And the same with the oral therapy. The risk of hospitalizations at 18 months were very similar between the two groups. So within the imprecision that was available in the trial, the results were very similar. An internal check that we did to see is that the expected benefit of long-acting antipsychotics versus oral antipsychotic is because it improves adherence. Long-acting injectable antipsychotic, if they work better, it's only because they enhance adherence. So we conducted a per protocol analysis as an internal check. If we had good data to adjust for confounding, then under conditions in which patients in the long-acting and in the oral group are both perfectly adherent to the strategies, then we shouldn't observe any difference. And this is what we see. When we do the per protocol analysis and we adjust using inverse probability weighting, we see an exactly null result, which in this case, the per protocol analysis was used as an internal check of our capacity to adjust for time-varying confounding. When we extended the follow-up, which was the thing that most clinicians were wondering, what would have happened with these trials if instead of lasting for 18 months when there is no result, what would have happened if we extended the follow-up for, let's say, 3 years? And if we extend the follow-up, we see what the clinical intuition was suggesting, that the long-acting injectable agent actually shows a lower risk of hospitalization. So there is a benefit, it only that it takes longer than the follow-up of the trial to observe that. So to close this first chapter, the FEP-CAUSAL collaboration is a consortium of clinical experts in first episode psychosis, but they also contribute data, observational data that we use. How do we use the observational data? We identify high-impact research areas where randomized trials provided inconclusive evidence, and we work together with the trialists to design the protocol of a target trial that provides and complement the results from those trials. We use the results of the trial as a benchmark to check our ability to reproduce and to give unbiased estimates in our observational analysis. Okay, so I'm going to use the next 10 minutes or so to highlight the other area of my research, which is suicide prevention in the VA. And this is a slightly different scenario because in this scenario, randomized trials are directly unavailable. And I will describe a little bit more what I mean when I say that trials are unavailable. So I don't need to say this, suicide is a major public health concern, especially in the US. It keeps increasing. It has been increasing since the 2000s. It's now the second cause of death among youth. And one of the strategies that we have to prevent suicide is not at a population-based level, but we can do what it's called indicated suicide prevention strategies, in which we identify groups that are at a particularly high risk of suicide, and we implement strategies that are only tailored to that particular group, to the group which is at a higher risk of suicide. The first candidate of group at a high risk of suicide are patients with mood or affective disorders. So because this group is at a particularly high risk of suicide, if we find and implement a strategy that prevents suicide in this candidate group, then we would be able to reduce suicide rates. That's the idea. A candidate to reduce suicide in this affective disorder population is lithium. And the reason why lithium is a candidate is because there has been a long history of research on proposing that lithium reduces suicide. There has been systematic reviews of randomized trials. I have to say, these randomized trials are not looking whether lithium initiation versus placebo initiation reduces the risk of suicide. What these trials are doing, these are trials that were designed for efficacy reasons. They were designed primarily to see if lithium works in affective disorders, so if it reduces hospitalization, relapses, and so on. But what they do in these systematic reviews is they compare whether in these trials a suicide was reported as an adverse event. These are very short trials, these are efficacy trials, and what they want is they want to see if in the adverse events there is any discrepancy between the adverse events of suicide in the lithium group versus the placebo. This systematic review was published in 2005 and found a very protective effect of lithium, but it was only based on 6 events in the placebo arm and 0 events in the lithium trial. So there were many trials, but either the events were not adjudicated, they were not reported as adverse events, so it has many shortcomings, this methodology. In parallel, there have been more than 20 observational studies suggesting a strong protective association between lithium and either no lithium or other mood stabilizers, and the odds ratio in this in meta-analysis of observational studies is extremely protective. Both because of the observational studies and the systematic review of randomized trials, clinical guidelines started to recommend that lithium must be used in patients at high risk of suicide. This is clinical guidelines for patients with affective disorders, and this is with an evidence grade A based on these 2 pieces of evidence. In the meantime, many investigators, because they saw the shortcomings of the systematic review of randomized trials, they started to do trials specifically looking at whether lithium prevents suicide or not. But the problem is that because suicide is such a rare event, it is impossible to look in a trial. The sample sizes that would be needed to see a difference in suicides would be huge, and it's impractical. So what trialists are doing is replacing the outcome of suicide by a surrogate outcome. And the surrogate outcome is called suicide-related events, which is a composite outcome of suicides, suicide attempts, suicide ideations, or hospitalizations that are made, or patients who are hospitalized to prevent suicides. So in these composite events, in trials that lasted for 1 or 2 years, the results are mostly null. So you can see, I try to summarize the most important trials, but you can see that most of these trials are null, suggesting that lithium has no effect in suicide-related events. The most important trial was published a couple of years ago. This trial was conducted at the VA. It's the largest trial ever conducted on this topic. And it showed that there's little evidence of any effect of lithium in preventing suicide-related events. So if we were to put this together, randomized trials, they provide unbiased estimate at baseline, but they are unavailable to look at suicide as the outcome. Instead, they need to look at a composite outcome of suicide-related events, and they have a short follow-up period. Observational studies, they are prone to confounding, but they are able, because of sample size, you can look at suicide, and of course, you can look at a longer follow-up period. So it seems that the optimal way forward, if we want to learn whether lithium prevents suicide or not, it seems that the best way is to combine the strengths from observational and randomized evidence. The first problem that comes to mind if we were to combine the strengths from randomized and observational studies is that observational studies are susceptible to confounding by indication. I shared with you clinical guidelines showing you that lithium should be prescribed preferentially to patients at high risk for suicide. And so you can see that after the publication of the guidelines, in studies that were conducted after 2013, you see a harmful effect of lithium on suicide. And if you look at the studies that were published before the publication of the guidelines, you see the opposite. And the opposite is essentially reflecting that for many psychiatrists, they know that lithium can be dangerous in an overdose. So for many years, psychiatrists were avoiding using lithium in patients at high risk of suicide. So you see this flip in the observational estimates, which is extremely suggestive of confounding by indication. And it also makes sense because in most observational databases, we don't have good data on suicide risk factors. We don't know in observation and in EHR data, claims data, registry data, we don't have clinical data on suicide. So emulating a target trial of lithium and suicide seems risky. We can face the same problem that observational researchers have faced in the past, that the estimates will be extremely susceptible to confounding by indication. So one approach that we can do is, instead of emulating the target trial of lithium and suicide, we can start with a more modest goal. We can start by emulating the protocol of the CSP590 trial, the trial that I showed you that was done in the VA, to look at the 1-year risk of suicide-related events among veterans with affective disorders. Why do we do this? We do this because the results from the trial can offer us a benchmark to see if we have the ability to overcome those biases that are present in observational data in suicide research. So if we wanted to emulate the target trial, which is the protocol of the CSP590 trial, this more modest goal on only looking at 1 year and suicide-related events, we have 2 difficulties. The first one is that to emulate randomization, we need clinical information on suicide risk factors. The VA offers a unique opportunity to overcome this difficulty, and it provides a unique opportunity because it's a national priority for the Veterans Affairs to reduce suicide risks. They do a number of things for clinical purposes, but as a secondary effect, they help researchers using EHR data. For example, all patients at high risk of suicide, they are flagged. Their electronic health records, they have a flag. So we can use these flags to identify patients at high risk of suicide, which is a variable that's crucial for confounding adjustment. They also conduct annual screenings on depression, alcoholism, suicide. So this also provides, of course, they do this for clinical reasons. They do this to screen the veterans and to early detect patients at risk. But it also helps researchers because we can now know with a better, with great detail, how their depression, how their alcoholism, their suicide, variables that are not typically available in any observational data set. If we use these variables in our analysis, we see striking differences between lithium initiators and non-initiators, huge standardized differences between the two groups. So you can see that for ideation, for high risk of suicide, for screening for depression or screening for suicide, there's huge imbalances, and these variables are not available in observational data. So prior studies, they had confounding for these variables, but they didn't have access to this clinical information. The second difficulty, if we were to emulate this trial, is the outcome misclassification. In the trial, they adjudicate suicide attempts with using an endpoint committee, but if we were to emulate this target trial using EHR data, we would use ICD codes, and that's problematic and creates a problem for specifically outcome misclassification, especially for suicide attempts that the properties of the phenotype for suicide attempt are not great. We can emulate the outcome adjudication in the target trial because in the VA, also since 2010, all suicide behavior was adjudicated by clinical providers. They created a data resource, which is called SPAN, in which psychiatrists, they adjudicate every suicide attempt or suspected suicide attempt. They speak with the patient, they speak with the family, and then they translate everything into a centralized database that's available for all VA sites across the US. So we can enhance our phenotype based on ICD codes. We can enhance that definition using the SPAN database to try to emulate what in the trial would be the outcome adjudication. After doing that, after including those confounders and enhancing the suicide attempt definition with the SPAN dataset, we replicated the results from the CSP590 trial, and you can see that the point estimates are also consistent with little effect of lithium initiation on the risk of suicide. There is, of course, some imprecision in the confidence intervals, but you can see that within that imprecision, the estimates from our observational analysis are largely compatible with the results from the trial. And this is something that increases our confidence that we can emulate our original plan, which was a target trial of lithium initiation and suicide with a longer follow-up period. One caveat here is I'm sure you have noticed that the absolute risks of suicide are lower in our observational analysis as compared to the absolute risks in the trial. And the reason for this is that there was one component of the suicide-related event definition that we were not able to emulate, which was hospitalizations that were made by the psychiatrist specifically to prevent suicides, because we didn't have access to the note from the psychiatrist mentioning the main reason for the hospitalization. Also, the trial investigators, they had access to clinical notes from outside care, which we didn't. So these two reasons mostly can explain the differences in the absolute risk, but the comparison between the two groups is preserved. So the next step would be to extend the analysis now that we can use the results from the trial to extend the results. And after extending the results to 10 years, we see that there is no effect of lithium on suicide, either in the intention to treat or the per protocol analysis. The two curves mostly overlap with each other. So to close, although there are no trials available that use suicide as the primary outcome, we had access to a trial that was looking at a similar outcome in a shorter follow-up period. So what we did was work in this paper that I showed you in the observational study. We also worked together with the trialists from the CSP590 trial, especially because the trial was done in the VA and we are using the same healthcare system. We are using the same data set. So learning from the trialists is also very useful when we design the protocol of the target trial emulation. And understanding the difficulties associated with this emulation, the lack of good data to approximate randomization and the lack of good data to approximate the outcome definition, both of them led to a successful benchmarking of the CSP590 trial. And then in the extension analysis, we were able to replicate the results from randomized trials, suggesting that there was no effect. So applying this two-step procedure essentially allowed us to align the observation and randomized results. These are acknowledgement about this research that was supported by the US Veterans Affairs. So to close, we are looking to expand this research direction, specifically in the VA. As I mentioned, many suicide-related events were undetected. We also think that we don't have, although we have many, we would love to have more risk factors for suicide to adjust for confounding, specifically in settings where confounding might be more challenging. So we think that the next step is to untap all the potential that's available in clinical notes to access suicide risk factors. The use of natural language processing or large language model seems to be the logical next step. One thing is that if we wanted to work with improving phenotypes for outcome definition, one idea is that if we keep working with trialists and we can, of course, use the events that were adjudicated in the context of the trial as the gold standard for fine-tuning if we were to use large language models. So the idea is to keep improving the communication between trialist and observational research and keep benefiting from each other. I emphasize how we benefit from the trialist, but I hope they also benefit from these discussions. These are two main areas of research that we identified. These are two trials that are conducted in the VA that we are planning to work on this similarly to what we did in lithium and suicide, do the same in these trials that are conducted within the VA. One is for the statins in the prevention of dementia, and the other one is for treatments for opioid use disorder and the risk of suicide, the risk of relapse, and the risk of hospitalizations for opioid use. I'm going to stop speaking now. Thank you. I think we have a few minutes left for questions. Camila, should I stop